Welcome to Mint. I am Jacob Koshy. While the recent media headlines might be dominated by the Novartis-Gleevec case, 2013 is also the year when, since it's been 30 years since the HIV/AIDS epidemic became a global national fear as well as a serious health issue for several governments. While India has admirably managed the epidemic within its borders, its rate of new infections has gone down by 50%, and it has managed to do this while addressing several risk groups simultaneously. To discuss more on these issues, we have with us Leena Menghaney of the Doctors Without Borders, and we also have Vidya Krishnan, the immense health writer, who will both take us through the complexities of tackling HIV/AIDS over the past 3 decades. So Leena, I'm going to start off with you. Of course, India has done a commendable job in controlling the HIV epidemic to a great extent. But wasn't this problem kind of exaggerated in the first instance? I mean, when you compare it over 30 years, what is your take on that?
Well, I think there are two fundamental things that we should take into consideration. One was the fact that there was a statistical correction in the methodology which led to a reduction of the numbers from 5 million to 2.5 million. Having said that, if you look at the response of the government, the first response were prevention strategies with high-risk groups.
Yeah.
Now those strategies have been in place and have started to slowly show an impact. But by no means are they fully working or reaching everybody. And these are the two major things that we have to think about.
Sure.
Are clean needles reaching all drug users? Do they have oral substitution therapy? And what we see on the ground is that's not necessarily true. Okay. Number two is with sex workers. The amount of police violence that they have faced has led to undermining of a lot of the HIV interventions with sex workers. Okay. So we have a long way to go with sex workers interventions in this country.
Vidya, she mentions high-risk groups. Now, what is your take on, has the profile or definition of what constitutes high-risk groups? I mean, has there been an evolution in that over the years?
Again, as Leena mentioned, we are yet to reach a point where there is universal coverage. Everybody who needs treatment is not on treatment as of now. But having said that, there has been a slight demographic shift. Recent data, India had concentrated pockets in the southern states and Maharashtra and Northeast. But because they focused targeted interventions in these 6 states, it has yielded some results. By no means we have addressed all the issues, but it has yielded some results, and the infection rate amongst men who have sex with men, commercial sex workers, injecting drug users, it has come down. Because this has come down, newer high-risk groups have emerged. Now, migrant workers were always a part of people who had to be targeted, but infection rates among them still continued to be high. Housewives, their wives, the problem with these groups are that they are amorphous. They are not concentrated in pockets where the government can go and address the problem. So the challenges that will now surface is that the government will have to come up with a policy which integrates the AIDS response. Instead of addressing it from a parallel structure that was set up outside of the public health system, it has to, unless it integrates it with general public health delivery, people who cannot be distinguished will not get the treatment that easily. So that's one of the challenges I wait to see how the policy will address.
If I could just come in, Leena, do you think there ought to be, she has mentioned this change in, different kinds of risk groups. What is your take on that? In the sense, do you need a radically different policy now in terms of addressing different kinds of risk groups?
See, I think fundamentally we have to recognize that the challenge with drug users, MSM and sex workers is by no means over. We need to continue working on these interventions, and those that are working well need to be replicated and
they're still the overwhelming big groups.
Yes. Even if you look at Mumbai, you will find that within the gay community, infection rates are quite high and services are poor. Okay. So it's not as if the vulnerable communities needs have all been addressed. However, the rights-based approach that the national program has adopted with a number of these groups and vulnerable groups is yielding a lot of results. For the simple reason that even if you look at Section 377, in the long run you need to integrate and scale up, because now you have a better legal framework to scale up interventions with the gay community. And similarly, for sex workers and drug users, we need to do more on the legal framework.
True.
That's one. But number two, I wanted to add that when you talk about the migrant population, the migrant population by its very nature has been neglected of all health services. So the first challenge is to give some basic health services to migrant populations. If you look at slums in Dharavi or you look at slums anywhere, or you see the migrant laborers who work within construction and others, you can reach out with basic health services. That is not being done. The last thing I would say is that I know there's a big rush to integrate the AIDS program into NRHM. I'm not necessarily a fan of that.
Why?
Because in a number of African countries where vertical programs have become part of the national health system, they have virtually they have undermined the kind of services people living with HIV have got.
Yeah, on a related point, I mean, integration apart, finances. I mean, right now, even even major donors like the Bill and Melinda, I mean, they are kind of paring down on their aid spending. So, what does that mean for controlling the
actually,
epidemic?
finances will not be the bigger challenges facing the government. They were financing only a very small, their envelope was very little, so we can do well without the Gates Foundation. The bigger problem again is to decide where we go further from here. I'm actually going to send this back to Leena about integration. On paper, these vertical programs actually have a huge financial constraint, and you have there is the fact that Global Fund is not cannot support AIDS initiatives as they were so far. And then at some point, India will have to look at a better policy instead of going disease after disease. We did that with polio. There are views that measles and other routine immunizations suffered because of that. There are better ways of strengthening basic primary healthcare centers, basic healthcare delivery. We are looking at universal health coverage. Would that not have a ripple effect on diseases like AIDS or tuberculosis?
I think I agree what happened on the polio program. There's no doubt it cannibalized the rest of the vaccine program.
Yeah.
But the AIDS program taught us a lot about public health. And we cannot forget that. We can't draw a parallel between the polio vaccine program and the AIDS program. The AIDS program taught us that rights matter when you do public health. Yeah. You did a population policy, it failed because you didn't integrate rights of women and their access to reproductive health care and sexual rights into the program. The AIDS program was the first one to do that. It was the first one to address sexuality, which doesn't exist within the whole public healthcare system. Vulnerable communities face huge amount of discrimination within the public healthcare system. And somehow, the NACO's program has made space for them within public healthcare systems. I think we are thinking too early of integration. According to me, if you don't take this step right, you could end up even messing up what you already have. And that's the big fear from AIDS activists. And I think a lot of us who struggle to see NACO up and going on services, whether it's prevention or treatment, fear that this integration could end up sort of undermining all of this stuff. Which other program actually looks at rights? Not the TB program, not the malaria program, none of them.
So in policy and implementation, I see, there are
huge
major challenges. But this last and final issue that I'd like to bring up is this thing about vaccines. So now, there is still a lot of interest and research in trying to come up with that HIV vaccine. I don't know how strongly it is going. But, there are so many recent research instances where, the baby in Mississippi, who they say has entered remission by detecting a cancer early and, going full on with those cocktail drugs. Now, do you think the quest for vaccines should continue, or should we just come up with, they should concentrate on new types of intervention? Like, there was also a report in, I think in Paris, where, they treated a set of HIV patients with, an early dose of extremely heavy antiretrovirals, and they seem to be fine. They've not been on medicines for some time, they seem to be fine. So should this vaccine thing continue, or should we just come up with smarter ways to...
See, I think we are not fundamentally against any kind of research, and particularly, if people want to pursue avenues of research, that should be the way to go for it. Some breakthroughs are unexpected and they happen.
But in light of decreased funding...
Yes, but I think one of the biggest concerns was that the the big mantra about vaccine that, once we have the vaccine and all will be resolved, they were eating up too many resources that we needed for treatment at that time. People were actually dying, and we were going after this, pot of gold which didn't even exist when we had the antiretroviral. So that was coming from the AIDS activists. What about people who are living with HIV? You're taking away all the finances in vaccine research. Number two, we've always, as MSF, believed that providing antiretrovirals, treatment is prevention. And that is being proven in different ways. Whether we provide antiretrovirals early on with higher CD4 counts and people stabilize and the viral loads go to undetectable. The big slogan of the AIDS movement is undetectable viral load. That's what we aim for. That means you cannot transmit the infection to your partners. And number two is this, that you yourself can lead a very extremely healthy life, including having children and doing living your life as you would want to.
Vidya, do you have any final closing thoughts on this in terms of gunning for vaccines, or we just go about plain and simple?
If there is a vaccine, nobody is going to say no to that.
But spending lots more money and looking for that.
Given the financial constraints and given what is relevant to the Indian context, I, especially as a journalist who watches this area, would be very interested in how the policy is revisited, how they reconstruct numbers, what are the strategies they come up with. And as someone who watches the space, it would be interesting to see whether they integrate, even if they integrate it with the public health system. We are hoping for a public health system which is not crumbling. We need more money in for the health sector. This was the 12th five-year plan where sweeping health sector reforms were supposed to take place. None of that has happened, and there are these big programs. So either which way we see, for journalists, it's a very exciting time to follow this, because NACP4 is going to start, and there is a demographic shift. There has to be a policy shift that quickly adapts instead of the government playing catch up with what is happening. So I'm very excited to be around to watch this and report in this area.
So clearly there's a lot of good news as far as India is concerned, but there are so many more challenges that continue to hover that we need to take care of.
I think the integration has to happen in a very different way.
Cool.
Being an AIDS activist and working with vulnerable communities and having friends over there, instead of integrating it into the public healthcare system, why don't we use NACO's expertise to expand it from HIV to hepatitis as well, which is a very big challenge in this country.
Sure.
You've got expertise on sexually transmitted infections. You can make it into treating sexually transmitted infections, which you have done. Expand it to hepatitis, which is also a sexually transmitted infection, hepatitis B. Provide the hepatitis B vaccines to vulnerable communities. Treat hepatitis C, which is killing people living with HIV who are co-infected. At that point, everyone says, no, NACO cannot take up this job. But everybody else wants to integrate it into the public healthcare system. I feel that just the opposite. Give the jobs that NACO's done best. Give them, they have the expertise to deal with vulnerable communities. They have the expertise to deal with a virus. And we're dealing with so many viruses. We're dealing with hepatitis B and hepatitis C. Give them that job. For me, that's the exciting part of taking NACO out of HIV. Not doing it the opposite way. I'm actually a naysayer on that. Do not integrate at this point of time. Slow down.
I am actually, if that happens, I will be, I'm no one to say which way the policy should go. I report on what happens there. But if they keep adding, I will be very skeptical. I don't feel very positive about creating these parallel structure and going disease after disease. AIDS is an exception because of the nature of the disease that is, and it requires rights-based intervention. But if we keep doing, if we replicate polio for measles and then replicate that for something else, and meningitis and this, that and the other, we have no money in the public health sector. So that is not a very intelligent way of solving a problem, especially when the purse strings, we are on a shoestring budget. So
I think, I think this is one of those very divisive issues that we can keep arguing on, but I think we should kind of...
you cut it here, but we can...
So clearly we have to come up with more innovative ways to keep addressing the future challenges that HIV/AIDS poses in India. So thanks a lot, Leena, for taking time out and joining us. And thanks a lot, Vidya, too. It was a pleasure.
Thank you.
That's all we have from you for this discussion. Keep watching Mint.